Okay, welcome back to Cardiovascular Lecture 15, Part 2. In this short video, we're going to consider the special features of the cutaneous circulation and its critical role in thermoregulation. The skin is a very large organ which serves as an interface between the body and the external environment. Although it makes up 1/3 of the body weight, the skin normally receives only 4% of the cardiac output. But powerful sympathetic regulation of the cutaneous circulation can divert a much higher or much lower proportion of the cardiac output to or from the skin. This is possible because although large, the skin is metabolically inactive. It performs relatively little work, so its metabolic needs and blood flow demands are minimal. And this low metabolic rate of the skin enables it to tolerate up to 10 hours of reduced blood flow. So cutaneous flow is not and does not need to be driven by local metabolic demand. Instead, cutaneous blood flow is regulated by nervous control through the sympathetic vasoconstrictor fibers. And this regulation by neural reflexes is aimed at two important tasks. First, regulation of core body temperature, thermoregulation. And second, as we have already seen, regulation of arterial blood pressure. Here's a cutaway view of the skin, which shows that the skin consists of two layers, the outer epidermis and the internal dermis, and this rests on a thin layer of brown fat that serves as insulation. The microvascular network that supplies the skin with blood is unique among organs. It's designed to function as an adjustable heat exchanger, and it has several special features. Near the surface of the skin, we find an extensive network of capillary loops called dermal papilla. The projection of these capillary loops into finger-like extensions of the dermis brings warm blood near the skin surface, where it can be eliminated by radiation, convection, and, in conjunction with sweating, evaporation. These capillary loops drain into a web of specialized venules, which are unusually large and distensible to form a large plexus. The word plexus is Latin for braid or branching network. There are actually two venous plexi in the dermis, one superficial and another deep cutaneous. Together, this interconnected venous plexus just under the skin surface serves as a reservoir for warm blood. And as we will see, blood can be diverted to or from the skin surface, in other words, to or from the dermal papilla and the venous plexi, and this is controlled by sympathetic vasoconstrictor fibers, shown here in green, that originate in the thermoregulatory center of the brain hypothalamus. The fires of cellular metabolism generate heat. Heat is a byproduct of cellular metabolism because many of its chemical reactions are exothermic, that is, they release heat. And this heat must be carried away from the tissues by the blood and released to the environment from the skin. And when the rate of cellular heat production is equal to the rate of heat loss, the body is in heat balance. The body actively regulates its core temperature around a very precise set point, which is approximately 37 degrees centigrade or 98 degrees Fahrenheit, although this set point can vary a bit with age and diurnal cycle. Still, in health, core temperature does not fluctuate by more than about 1 degree C. Core temperature can be measured most accurately with a thermometer inserted into either the rectum or the esophagus, although reasonably good estimates of core temperature can be measured in the mouth or the axilla. But keep in mind that oral temperature will be about a 0.5 degree C lower than true core temperature, and axilla temperature will be about 1 degree C lower than true core temperature. A core temperature below 35 degrees C is considered hypothermia, and a core temperature above 38 degrees is called hyperthermia. Hyperthermia is not always pathological. It can occur in exercise or in extreme heat, but it can occur in common pathological circumstances like fever. The skin is a thermoregulatory organ, so it's not surprising that its blood supply depends largely on the body core temperature. Let's perform an experiment. Suppose we measure blood flow through the cutaneous circulation as a function of time. If we place a subject in a room at normal temperature, blood flow to the skin is a small fraction of its maximal. If the subject is then abruptly placed in a cold room, blood flow is diverted away from the skin, the loss of heat from the skin is decreased, and this helps conserve core temperature. We will see that this is achieved by cutaneous vasoconstriction. Next, If the individual is returned to a room at normal temperature, sympathetic vasoconstriction of the cutaneous vessels is withdrawn and blood flow is normalized. Here, the test subject is transferred into a hot room. There is a complete withdrawal of sympathetic vasoconstriction, and the cutaneous capillaries fill with warm blood, allowing that excess heat to be eliminated from the skin surface. With continued exposure to heat stress, we will eventually see a phase of strong, active vasodilation in the cutaneous vessels, and the pooling of blood in the distended venous plexi is what causes the skin to become flush, red, at least in lightly pigmented individuals, and very warm to the touch. Now, blood flow to the superficial layers of the skin is maximal, and this allows for rapid transfer of heat from the skin surface. In fact, in severe heat, as much as 60% of the cardiac output may be diverted to the cutaneous circulation in an emergency attempt to eliminate heat and reduce core body temperature. Recent research has established that this response involves an activation of cholinergic vasodilator nerve, and they appear to act by causing a local release of the dissolved gas nitric oxide. We've learned that NO is a powerful vasodilator hormone, and this plays some part in maximal cutaneous vasodilation. However, this mechanism remains poorly understood. The main thermostat that controls cutaneous blood flow is located in the hypothalamus of the brain. This is the so-called central thermal receptor. The molecular sensor is a temperature-sensitive TRPV cation channel in the hypothalamic neurons. This TRPV1 cation channel is also known as the capsaicin receptor or the vanilloid receptor. Superimposed on this global regulation of cutaneous blood flow, there is modulation of local blood flow by additional thermoreceptors located in the skin itself. So cutaneous blood flow is regulated globally by body core temperature via hypothalamic thermoreceptors and locally by surface body temperature by peripheral thermoreceptors. There are three main effectors for heat elimination: the cutaneous blood vessels, which can bring blood or divert blood from the skin; the sweat glands in the skin, which can secrete water for the purpose of evaporative cooling; and the skeletal muscles, which can shiver and generate extra core heat. Thermoregulation is a classic negative feedback control loop that involves these sensors and effectors. When the body core temperature is too high, it exceeds the hypothalamic thermal set point. The hypothalamus activates cooling mechanisms, including cutaneous vasodilation, which brings warm blood to the skin surface where the excess heat can be eliminated, and sweating, which cools the skin by evaporation. On the other hand, if body temperature falls below the hypothalamic thermal set point, the hypothalamus instead activates warming mechanism, including cutaneous vasoconstriction, which diverts blood flow away from the skin surface to conserve core temperature, and the activation of skeletal muscle shivering to generate heat into the core. And these processes continue until the set point is restored. Now don't forget that the arteriolar smooth muscle cells in the skin prominently express alpha-1 adrenergic receptors, which are programmed to cause constriction. Norepinephrine in the blood activates these receptors, and recall that the norepinephrine is released into the blood by the adrenal medulla in response to sympathetic input. And one more reminder, the skin, like the gut, is especially responsive to sympathetic neural input. This is because the cutaneous arterioles are innervated by numerous sympathetic fibers, and like we've just seen, the smooth muscle cells prominently express those alpha-1 adrenergic receptors. So the skin is powerfully affected by sympathetic neural input. So we've already talked about the capillaries of the dermal papilla, these finger-like extensions toward the skin, which bring warm blood to the surface of the skin to promote heat loss. We've also talked about the venous plexus, which can be filled with warm blood to bring heat closer to the surface. What we have not talked about yet is another special feature of the cutaneous circulation, and these are the arteriovenous anastomoses. The word anastomose means a cross-connection between adjacent channels, and that's exactly what these AV anastomoses do. They shunt blood directly from the arteriole into the venous plexus to cause its engorgement. These AV anastomoses are particularly prominent in the so-called acral skin. This is the skin that lacks hair. The fingertips, the palms of the hands, the soles of the feet, the toes, the ears, the nose, the lips, These regions of the skin are prominently equipped with these AV anastomoses. So let's review the thermoregulation responses on the level of the microvasculature. When the body or a region of the skin is too warm, sympathetic vasoconstrictor tone will be withdrawn. This is a negative influence on sympathetic input to the dermal arterioles and the AV anastomoses. And this withdrawal of vasoconstrictor tone will permit blood to flow into the capillary loops and the venous plexi. As a consequence, the skin will become engorged with warm blood, allowing heat to be conducted to the surface and dissipated faster. And this will produce the characteristic warm red skin, as we can see on a light-skinned individual in heat. On the other hand, if the body core temperature or a region of the skin is too low, the hypothalamus will excite these sympathetic vasoconstrictor fibers projecting to the skin, and the increased release of the neurotransmitter norepinephrine will act on these alpha adrenergic receptors on the arterioles of the venous plexus and the dermal papilla, causing constriction. The flow of warm blood will be diverted away from the skin surface, helping the body retain core heat. And the loss of blood flow will cause the skin to become cool and pale. In our next lecture on circulatory shock, we will learn that two of the four forms, cardiogenic and hemorrhagic shock, can be differentiated because the patients will have cool, pale skin. In contrast, the other two forms of shock, septic and neurogenic shock, will have warm red skin. So here is a summary slide that lists all of the important special characteristics of the cutaneous circulation. Go through each one of these, test your understanding, see if they make sense. And now a quick overview of the skeletal muscle circulation, which we've already touched on in previous lectures. There are two important features of skeletal muscle. First, it is an enormous mass of tissue. Skeletal muscle constitutes about 40% of the body mass, so it dominates SVR. So flow must be limited in resting fibers. But its demand can change tremendously. When not contracting, skeletal muscles consume very little oxygen. At rest, only 10% of the capillaries in skeletal muscle need to be perfused at any given moment, and so the skeletal muscles steal away only about 15% of the cardiac output. But during strenuous exercise, skeletal muscles may consume oxygen 50 times faster, and to meet this demand, they may steal away as much as 85% of the cardiac output. And because skeletal muscle is the biggest contributor to systemic vascular resistance, it plays a major role in regulating arterial pressure. Remember that neural control factors predominate at rest. Tonic activity of the sympathetic vasoconstrictor neurons minimizes blood flow to the non-working skeletal muscles. But as soon as the skeletal muscles begin to work in exercise, neural control of blood flow is quickly overridden by local metabolic vasodilators, which accumulate in the working muscle. And finally, like the coronary circulation, blood flow through skeletal muscle is periodically inhibited by vascular compressions during muscle constriction. So the vasodilation seen in exercise must be great enough to permit very large flows in the intervals between contractions. And at the same time, compressions of the veins help milk the blood back to the heart, and this is the so-called skeletal muscle pump. And this concludes Lecture 15. Thanks again for your attention.